If you are over 60 and you are taking vitamin D right now, I need you to stop and watch this video before you take your next dose. Not because vitamin D is harmful, it is not. In fact, for older adults, maintaining healthy vitamin D levels is one of the most important things you can do for your bones, your immune system, your heart, and your brain. I want to be very clear about that from the beginning, but here is what almost no one is telling you, and what I have seen cause serious preventable problems in patients who were doing everything they thought was right. Vitamin D does not work alone. It depends on a specific mineral to function correctly inside your body. Without that mineral, vitamin D cannot do its job properly. And in some cases, taking high doses of vitamin D without that mineral can actually shift calcium into places in your body where it should not go, including your arteries, your kidneys, and your soft tissue. And that mineral is vitamin K2. And the vast majority of older adults who take vitamin D are not taking K2 alongside it. I have spent over 2 decades working with older patients managing chronic conditions, cardiovascular risk, bone loss, and metabolic decline. I have reviewed labs, adjusted supplement regimens, and had countless conversations with patients who were frustrated that their vitamin D levels were correcting on paper, but their health outcomes were not improving the way they expected. In many of those cases, the missing piece was K2. I want to tell you about a patient I will call Margaret. She was 68 years old, health conscious, active, and following her doctor's advice carefully. She had been taking 5,000 IU of vitamin D3 daily for nearly 2 years after her blood work showed she was deficient. She was also taking calcium supplements because her doctor had flagged early bone density concerns. What nobody told Margaret was that without K2, the calcium her body was absorbing had no proper direction. Her follow-up imaging showed arterial calcification that had not been present 2 years earlier. She was not in crisis, but the pattern was deeply concerning. She had done everything right and still ended up with a problem that was largely preventable. That is exactly why I am making this video. By the time you finish watching, you will understand what K2 actually does inside your body, why this partnership with vitamin D is not optional for people over 60, what the real warning signs of calcium misplacement look like, and what you need to do today to make sure your supplement routine is actually protecting you instead of quietly creating a new risk. This is not about fear. This is about getting the full picture, because you deserve to make decisions with complete information. Stay with me, because what I am going to explain next surprises most people the first time they hear it. Most people who take vitamin D believe the process is straightforward. You are deficient, your doctor recommends a supplement, your levels rise, and your body benefits. That is the assumption. And on the surface, it seems logical. But here is what is actually happening inside your body that most supplement labels will never explain to you. When you take vitamin D3, your body uses it to dramatically increase calcium absorption from the food you eat and the supplements you take. This is one of vitamin D's primary jobs. Without adequate vitamin D, your gut absorbs very little calcium. With it, absorption increases significantly. For older adults with bone loss concerns, this sounds exactly like what you want. The problem begins at the next step. Once calcium enters your bloodstream, it needs direction. It needs to be guided toward the right destinations, primarily your bones and your teeth, and away from the wrong ones, primarily your arteries, your kidneys, and your soft tissue. Calcium floating freely in your bloodstream without proper direction is not neutral. It is a cardiovascular and kidney risk. This is where vitamin K2 becomes essential. Think of the system this way. Vitamin D is responsible for opening the door and letting calcium into your bloodstream. Vitamin K2 is responsible for telling that calcium where to go once it is inside. K2 activates 2 critical proteins in your body. The first is called osteocalcin, which pulls calcium into your bones and holds it there. The second is called matrix GLA protein, often abbreviated as MGP, which actively removes calcium from your arteries and soft tissue and prevents it from depositing there. Without K2, those proteins remain inactive. Osteocalcin cannot anchor calcium to your bones effectively. MGP cannot clear calcium from your vessel walls. The calcium your vitamin D helped absorb has nowhere to go except wherever blood flow carries it, and over time, it begins to settle. This process has a name. It is called vascular calcification, and in older adults, it is directly linked to arterial stiffness, rising blood pressure, and increased cardiovascular risk. Here's the critical point. You can have perfectly normal vitamin D blood levels, feel confident that you are supplementing correctly, and still be experiencing this internal calcium misrouting without a single obvious symptom in the early stages. That is the hidden danger, and it is far more common in seniors over 60 than most people realize. What I want to explain next is why people over 60 specifically are at much greater risk for this problem than younger adults, and why age alone changes how urgently K2 matters to your supplement routine. The reason this matters so much more after 60 comes down to a combination of factors that are specific to how the aging body processes nutrients, manages calcium, and maintains vascular health. This is not about general vulnerability. There are precise physiological reasons why older adults face a meaningfully higher risk. First, consider how vitamin K2 levels change with age. As you get older, your body's ability to synthesize and absorb fat-soluble vitamins, which includes both vitamin D and vitamin K2, declines. Dietary sources of K2 are already limited for most people. K2 is found primarily in fermented foods like natto, certain aged cheeses, and some animal products. Most older adults in Western countries are not consuming meaningful amounts of these foods regularly. Studies have consistently found that K2 insufficiency is widespread in older populations, even in people who consider themselves health conscious. Second, many seniors over 60 are taking multiple supplements and medications that further complicate this picture. Warfarin, one of the most commonly prescribed blood thinners in older adults, directly interferes with vitamin K activity. Statins, proton pump inhibitors, and certain cholesterol medications can also affect how fat-soluble vitamins are absorbed and utilized. If you are on any of these medications, the interaction between your supplement routine and your prescriptions is something that requires careful, individualized attention from your doctor. Third, the aging arterial system is already more susceptible to calcification. As arteries age, their structural integrity changes. The smooth muscle cells lining blood vessel walls become more prone to calcification under conditions of low K2 and elevated circulating calcium. This is not a theoretical risk. Arterial stiffness is one of the leading contributors to elevated systolic blood pressure in older adults, and vascular calcification is a measurable driver of that stiffness. Here's the practical action step for this chapter. If you are currently taking vitamin D3 and you are not also taking vitamin K2, the immediate step is not to stop your vitamin D. The step is to speak with your doctor about adding K2, specifically the MK7 form of K2, which has a longer half-life in the body and has shown the strongest evidence for arterial and bone health in clinical research. Do not adjust your regimen without that conversation, particularly if you are on any anticoagulant medications, but do have that conversation soon, because what I'm going to show you next is what this process looks like when it has been going on silently for years, and the signs that may already be present in your body right now. One of the reasons vascular calcification goes undetected for so long in older adults is that its early warning signs are easy to dismiss, easy to attribute to normal aging, and rarely connected by patients or even some clinicians to a calcium and K2 imbalance. Let me walk you through what these signs can look like, because awareness here is genuinely protective. The first sign is persistently elevated systolic blood pressure, particularly when it has been gradually rising over several years despite reasonable lifestyle management. When arteries lose flexibility because of calcium deposits in their walls, the heart has to work harder to push blood through. The result is a steady upward drift in blood pressure that does not respond well to standard interventions. If your top number has been climbing and your doctor has not yet investigated arterial stiffness as a potential contributor, this is worth raising. The second sign is changes in how your heart sounds or functions. Aortic valve calcification is a condition where calcium deposits accumulate on the heart's aortic valve, reducing its ability to open and close properly. This can begin with subtle symptoms including fatigue during mild exertion, occasional chest tightness, or a feeling of reduced stamina that you might be attributing to normal aging. It can also present with no noticeable symptoms at all for a significant period of time before it becomes clinically apparent. The third sign involves kidney function. Your kidneys filter your blood continuously. When calcium levels in the bloodstream are chronically elevated without adequate K2 direction, the kidneys bear the filtering burden. Over time, calcium crystal deposits can form within the kidney tissue itself. If your recent lab work has shown changes in your GFR, your creatinine, or your kidney function markers, and you are taking high-dose vitamin D without K2, that connection deserves discussion with your physician. The fourth sign is one that surprises many of my patients. It involves muscle cramps, joint stiffness, and unusual calcification in tendons or soft tissue around joints. When calcium migrates into soft tissue rather than bone, it can create localized deposits that cause pain and restricted movement. This is sometimes written off as arthritis or general aging when the actual driver may be a calcium distribution problem. None of these signs on their own confirms a K2 deficiency, but when they appear in an older adult who is taking vitamin D without K2, the connection is clinically significant and worth investigating. What I want to address next is the bone health side of this equation, because this is where many seniors feel the most confusion about whether they are doing the right thing or not. For millions of older adults, particularly women over 60, the conversation about bone health has centered on two things: vitamin D and calcium. Those are the two supplements most commonly recommended, most frequently discussed, and most widely taken. And that recommendation is not wrong, but it is incomplete in a way that matters enormously. Here is the escalation that I want you to understand clearly. When you take vitamin D and calcium together without K2, you are potentially creating a situation where your bones are still losing density while your arteries are gaining it. This is not a theoretical concern. Research published in peer-reviewed cardiology and endocrinology journals has documented this inverse relationship. Low K2 status has been associated with both increased bone loss and increased vascular calcification occurring simultaneously in the same individuals. Think about what that means practically. You are taking supplements specifically to protect your bones, and the absence of one cofactor means that the calcium you are absorbing may not be anchoring into bone tissue the way it should, while at the same time it may be contributing to arterial deposits that raise your cardiovascular risk. The outcome is the opposite of what you intended. Osteocalcin, the protein that K2 activates to pull calcium into bone matrix, is produced by your bone-building cells, but it remains in an inactive form called uncarboxylated osteocalcin unless K2 is present to carboxylate it. Elevated levels of uncarboxylated osteocalcin in the blood are now recognized as a clinical marker for both poor bone quality and higher cardiovascular risk. Some laboratories can measure this directly, and it is worth asking your doctor about if bone or heart health is an active concern for you. The action step here is twofold. First, if you have had a DEXA scan showing bone density concerns and your response has been to increase calcium and vitamin D, make sure K2 is part of that regimen. The three work as a system, not as independent supplements. Second, ask your doctor whether a coronary artery calcium score, also called a CAC score, is appropriate for you. This is a simple, low-radiation CT scan that can measure the degree of calcium deposits already present in your coronary arteries. It provides a direct window into vascular calcification that blood tests alone cannot show. For adults over 60 with cardiovascular risk factors, it is an increasingly valuable diagnostic tool. Now, I want to pause here for a moment because I want to hear from you directly. And what I am about to ask may help you recognize something important about your own situation. Before I continue, I want to ask you something directly, and I want you to take a moment to actually think about your answer. Are you currently taking vitamin D, and have you been taking it without K2? If the answer is yes, type the word yes in the comments right now. You do not need to explain anything, just that one word, because I want to know how many people watching this video are in exactly this situation, and I want you to know that you are not alone if you are. I have had this conversation in my office more times than I can count. A patient comes in feeling like they are doing everything right. They are taking their vitamin D. They are taking their calcium. They are watching their diet, and yet something is still not adding up in their labs or their symptoms. In most of those conversations, K2 has never been mentioned to them. Not by their doctor, not by the pharmacist, not on the supplement label. That is not a failure of the patient. It is a gap in how this information gets communicated. Now, here is what I want to add in this chapter that builds on everything we have covered so far. The form of K2 you take matters. There are two primary forms available in supplements, MK4 and MK7. MK4 has a very short half-life, meaning it clears from your system quickly and requires multiple doses per day to maintain consistent blood levels. MK7, which is derived from fermented natto, has a significantly longer half-life and remains active in the body for a much longer duration with a single daily dose. For older adults, MK7 is the form with the strongest current evidence for both bone and cardiovascular benefit. When you look at a supplement label, look specifically for menaquinone 7 or MK7 on the ingredient list. A typical dose used in research ranges from 90 to 200 micrograms per day, though your doctor should help determine the right amount for your individual situation. And because K2 is fat-soluble, like vitamin D, it should always be taken with a meal that contains some dietary fat for proper absorption. What comes next in this video is where things become even more serious for a specific group of older adults, and you need to hear this part carefully. There is a specific group of older adults for whom this vitamin D and K2 conversation carries an even higher level of urgency. And that group is larger than most people realize. If you have any of the following conditions, the risk associated with taking high-dose vitamin D without K2 is meaningfully amplified. The first condition is chronic kidney disease. Your kidneys play a central role in vitamin D metabolism. They are responsible for converting vitamin D into its active hormonal form, calcitriol. When kidney function is compromised, this conversion process is disrupted. At the same time, the kidney's ability to manage calcium excretion is also impaired. In patients with stage 3 or higher chronic kidney disease, high-dose vitamin D supplementation without careful medical supervision and without K2 can accelerate the very calcification process that further damages kidney tissue. If you have been told your kidney function is reduced, your vitamin D and K2 regimen must be managed directly with your physician, not self-directed. The second condition is existing cardiovascular disease. If you have already been diagnosed with coronary artery disease, have had a heart attack, have had a stent placed, or have known arterial calcification, you are not starting from a neutral baseline. The calcification process may already be active and established. In this situation, K2 supplementation may still be beneficial, but the urgency of getting your doctor involved in this decision is absolute. Do not assume that adding K2 on your own is safe without that guidance, particularly given potential interactions with cardiac medications. The third condition is a history of hypercalcemia, which means chronically elevated calcium in the blood. If you have ever been told your blood calcium is too high, taking vitamin D in supplemental doses without close monitoring is genuinely dangerous, and K2 alone is not an adequate safeguard in that scenario. Here is what I want you to take from this chapter. The stakes of getting this right are not the same for every person. For a generally healthy 62-year-old taking moderate vitamin D, the risk of going without K2 is a gradual one that builds over time. For a 74-year-old with existing kidney compromise and cardiovascular history, the same situation carries acute clinical relevance. Knowing which category you are in is not guesswork. It requires a conversation with your doctor and updated lab work. And what I am going to address next is one of the most commonly overlooked aspects of this entire conversation, something that connects vitamin D, K2, magnesium, and blood pressure in a way that very few older adults have ever been told. There is one more piece of this puzzle that I have not yet addressed, and it is something I consider critically important for any older adult who is serious about managing their blood pressure, their heart health, and their overall cardiovascular risk. Vitamin D does not just depend on K2. It also depends on magnesium. Magnesium is required for the conversion of vitamin D into its active form in your body. Without adequate magnesium, the vitamin D you take cannot complete its activation process. It remains in an intermediate form that cannot exert its intended effects. This means that if your magnesium levels are low, your vitamin D supplementation may be producing lab results that look normal, while the functional activity of vitamin D inside your cells is still impaired. Studies have found that a substantial portion of older adults are magnesium insufficient. This is not always a dramatic clinical deficiency. It is more often a quiet, subclinical shortfall that does not trigger obvious symptoms, but steadily impairs multiple physiological systems, including vitamin D activation, blood pressure regulation, insulin sensitivity, and heart rhythm stability. Magnesium also has a direct relationship with calcium. These two minerals act in opposition at the cellular level. Magnesium helps regulate how calcium enters cells and how it is cleared. When magnesium is low, cellular calcium activity becomes dysregulated, contributing to muscle cramps, arterial tension, elevated blood pressure, and sleep disruption, all of which are symptoms that older adults frequently experience and frequently attribute to other causes. The practical message here is that for older adults over 60, vitamin D supplementation ideally exists within a trio of cofactors: K2 to direct calcium appropriately, and magnesium to activate vitamin D and regulate calcium at the cellular level. The form of magnesium matters as well. Magnesium glycinate and magnesium malate tend to be better tolerated by older adults and are less likely to cause the digestive side effects associated with magnesium oxide, which is the cheapest and most commonly sold form, but also the least bioavailable. Again, discuss dosing with your doctor. But knowing this connection exists is the first step to asking the right questions. Now let me bring everything together for you in a clear, actionable summary that you can actually use. Everything I have walked you through in this video points to one central truth. Vitamin D supplementation in older adults is not a standalone action. It is part of a physiological system that requires specific cofactors to function correctly and safely. Taking vitamin D without understanding this system is like putting fuel in a car without checking whether the engine and the delivery components are working properly. The fuel is not the problem, the incomplete system is. Here is what I want you to do based on everything you have heard today. The first step is to review your current supplement routine before your next dose. Write down what you are taking, the doses, and the forms. Note whether K2 and magnesium are already present. If they are not, that is the starting point for your next conversation with your doctor. The second step is to schedule a conversation with your physician specifically about this topic. Bring your supplement list. Ask directly whether your vitamin D dose is appropriate for your current kidney function and cardiovascular status. Ask whether K2, specifically MK7, should be added to your regimen. Ask whether your magnesium levels have been recently evaluated. The third step is to request updated lab work if it has been more than 6 months since your last comprehensive metabolic panel. This should include your vitamin D 25OH level, your serum calcium, your kidney function markers including GFR and creatinine, and if possible, a magnesium level. Some forward-thinking physicians may also order an uncarboxylated osteocalcin level or discuss a KAC score depending on your individual risk profile. The fourth step applies specifically if you are taking Warfarin or any other anticoagulant. Do not add vitamin K2 to your supplement routine without explicit guidance from your prescribing physician. K2 interacts with warfarin in ways that can affect your INR and your anticoagulation status. This is a conversation that absolutely must happen before any change. The fifth step is a dietary one. Increase your intake of foods naturally rich in K2 where possible. Aged hard cheeses, egg yolks from pasture-raised chickens, and grass-fed butter contain meaningful amounts of MK4. Natto, a fermented soybean product, contains the highest known food concentrations of MK7 and is worth exploring if it fits your dietary preferences. The sixth step is timing. Take your vitamin D, K2, and magnesium with your largest meal of the day, the one that is most likely to contain dietary fat, to maximize absorption of all three fat-soluble or fat-enhanced nutrients. None of these steps are complicated, but together they represent a meaningfully more complete and more protective approach to supplementation than most older adults are currently following. I want to close this video by speaking to you directly, not as a content creator, but as someone who has spent a long time watching patients navigate exactly the kind of gap this video addresses. The gap between doing something right and doing something completely right is often very small in theory. In practice, that gap can widen into consequences that take years to develop and are much harder to address once they are established. Arterial calcification that builds slowly over 5 years of unguided supplementation does not reverse overnight. Bone loss that continues because calcium was never properly directed does not recover with a single course correction. Early action matters in a way that late action simply cannot replicate. You watched this video. That already puts you ahead of most people in your position. You now understand something that is not commonly discussed, not commonly taught, and not commonly found on the back of a supplement bottle. The relationship between vitamin D, K2, and magnesium is not a niche topic for researchers. It is directly relevant to your heart, your bones, your kidneys, and your long-term independence. Here is the one immediate action I want you to take today. Before you take your next dose of vitamin D, look at the label and ask yourself one question. Is K2 also in this bottle? If the answer is no, put that supplement down, pick up your phone, and schedule a conversation with your doctor. That is it. That single act of pausing and asking the question is where the protection begins. If someone you love is over 60 and taking vitamin D, please share this video with them. You may be giving them information that their own doctor has not yet had time to communicate. That share takes 10 seconds and could matter far more than you realize. If this video helped you understand something you did not know before, leave a comment below. Tell me whether you were already taking K2 or whether this was new information for you. Your response helps me understand what content genuinely serves this community, and it helps other viewers know they are not alone in navigating these questions. And if you are not yet subscribed to this channel, now is a good time. Every video we produce is built around the same commitment, giving older adults the precise, medically grounded information they need to make better decisions about their health before problems become harder to manage. You deserve complete information. You deserve to supplement with confidence. And you deserve to age with your health working for you, not quietly against you. Take care of yourself. And I will see you in the next video.